So high angle means, so is a high angle. So this angle if it goes like this, it is high angle. If it goes like this, it is low angle. Okay. So low angle cases, they generate high masticative forces. So implant better to place good support. Okay. Do not do minimal implants. And if you see the right side masseter has been little hypertrophy. So this is the smile picture. We need to take bite smile. Okay. So this patient is a normal smile. Slightly patient is open, but you have to take a bite and smile picture. It will tell the correct VD. Okay. So the VD will reduce because of many reasons for the patient. One is because of attrition, that we know. And because of perio issues also, VD will reduce. Because perio problem, the tooth will flare out or they will intrude and slowly the patient will overclose. This patient I feel like this. If you see, there is no dark space here. There is no dark space. That is because of perio issue, the tooth has been buccally going out. Because of perio problem and because of tongue pressure also. So whenever you see this kind of buccal flaring, they will be overweight. Why? How overweight is related to the tooth flaring? Because when they put on weight, that means more fat is deposited. When fat is deposited from top to bottom, it will be deposited in the tongue also. Okay, so the tongue enlarges, it gives pressure. So this is one of the common reasons for ortho relapse. Okay, whenever you see ortho relapse, you have to think about from this angle also. The patient might have put on weight. The tongue also will gain fat deposition in weight. So that is why when a new patient comes, we record weight also. That is why there is a weight machine also. Okay. Some patient tell after treatment my cheeks went inside. So when we check, they might have reduced 5 or 6 kgs. Okay. Especially ortho patients, we have to follow the weight. Okay, this is the intraoral view. You can see the flaring out. So whenever this kind of flaring happens, what you see is buccally it will look normal. All the bone loss happens lingually because of the lingual pressure. That we can see from the CBCT. Multiple, you can see arch with this increased from here to here. Okay. Here also lower also arch with this reduced. Whenever possible, if this view is available, you can see it. If you see lingually, you can see the comparatively, lingually there will be bone loss. I don't know why there is more lingual bone loss for patients. Maybe because of hygiene is difficult on that side, or maybe because of force. Instantly you can see this distal additional supranumerary root. So this is the upper premolars bone loss on the palatal aspect. Upper anteriors you can see the bone loss. Okay. The VDA also has reduced because of buccal flaring. So for this kind of patients, it is difficult to do a single jaw. If you do single jaw, the upper teeth are flared up. So where to give tooth? To give in an ideal position or still to give the tooth in the still flare, giving occlusion is not difficult. Yeah. So this is an important view. This bone is the alveolar bone. Already alveolar bone is lost, the labial alveolar bone is. So how much bone is present? How much bone is present above the apex? This is the C2, right? This is the C2. Okay. For some patient, the apex will be here. Naturally, they have very less C2, basal bone. So you have to think from some patient they will have a root apex here. They will have a lot of bone between the nasal floor and here. So check these things. So now we will plan for the lower jaw. One interesting thing what I found is whenever you see mental foramen, you have to look for two things. Mesodistally where it is located. Most of the time it is in the second premolar, but rarely it is in the mesial root of first molar. Very rarely it is in the in between 4 and 5, but not near 4, but mostly it will be between 4 and 5. The more the foramen is distal, the more it is good for us. We can place the premolar implant in a good position, anterior interforaminal area will be available for us. And what is the height level? Alright. What is the height? At what height it is present? Whether it is present here or whether it is here. Comparatively, from the crest, how depth it is present. It is little superficial comparatively. Compared to the yesterday cases, it is comparatively superficial. Maybe the bone level was still here, I don't know. Or by nature the patient has a mental foramen. So mesodistally, what is the location? From the crest, what is the location? So during surgery, it will help you to find the mental foramen. During flap elevation, you will exactly know, okay, I am in the premolar, within 5 to 6 mm, I will see this. Otherwise, you will be searching here, 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 here. Okay. So exactly if you pinpoint this, because in mandible, you have to place implant in the interforaminal area. So you have to find the mental foramen first. Okay. So lower planning, as already told. First planning is alveoloplasty. How much alveoloplasty you have to do? Yesterday case, the lower anteriors was very much supraerupted. We did alveoloplasty here. Here there is not much supraeruption at all, but we need to remove this thin alveolar bone, and to create prosthetic space we need to do some maybe 3 mm alveoloplasty. Okay, so that is the alveoloplasty plan. Alveoloplastic plan is based on the clinical photo and this view. Even panoramic view will give you a fair idea. Second plan is number of implants, then location, then design, diameter and length, then angulation. In what angulation you are going to place, whether straight or angulated. Since it is a muscular hypertrophy, heavy chewer, square face, low angle face, better to go for a 8 implants. Okay. So that means anteriorly 2 implants. Okay, in between the mental foramen, and maybe 2 in the molar areas. There is one general rule. You can take it as a tip. The distance between this mental foramen and this mental foramen is, from the midline. Okay, this is the midline. If you measure 21 mm till 21 mm. Till 21 mm, it is without any mental foramen. The mental foramen is only beyond the 21 mm as per articles and studies. Okay. Anyhow, you are going to open the flap and see the mental foramen, but in some cases it may be a fully healed ridge. You don't want to open the flap, so you can use it as a guideline. Just will measure and check whether this is true. Okay, this is around 27. Okay, sometimes it will be 23. So 27 means we have got a lot of good bone. Interforamina area is very good. So we will plan first in the panoramic view. We will think that there is no CBCT available. Okay, we have got only X-ray. So it looks like there is a mental foramen here. So this kind of instances, you have two options. One is take IUP, the premolar area. It will give a fair idea. Okay, we'll take it as a here maybe. We'll think. I don't know. Okay. So interforamina 4 implants. First premolar 1 implant. Okay. Even the mental foramen is not visible in the OPG or whatever it is. Anyhow, you can open the flap and see it directly. Okay. Here 1 and first premolar 1. Okay. What is the diameter? We don't know. We don't know the buccolingual width. So either you have to go for CBCT. If there is no CBCT, once you open the flap, you will know it. Mostly you can place 3.75 or 4 something. Okay. Here also the same. What is the length? That also we don't know. Even if you measure here, in the panoramic view you measure from here to here, you should not believe it. Because buncolingually, the mandible is not like this. The mandible is like this. You may measure 20 mm here. If you put a 20 mm drill, you may go here. Because there is a curvature in the lower mandible, right? This is buccal, this is lingual, right? There is a C-shaped curvature. It is not a straight bone. You may take a drill and you may drill like this. But actually you will be measured in the X-ray from here to here. So the length determination don't do. During drilling, anyhow you are going to feel the resistance and respect the resistance and stop and measure it. That's it. So both the diameter and length can be decided surgically. And of course lateral incisor you are going to place your lateral one. The diameter, what is the diameter? During surgery, the length the same. Okay. So that means interforamina implants you can place without seeing CBCT.
X-ray.
Even without seeing X-ray you can do it. Unless there is some pathology is there, no.
Okay.
Straightforward case. Intraoperative only by feel, by respecting the resistance, by doing slowly, by opening the flap. Yes. This
But அது வெறும் lower mandibles க்கு தான் இல்ல IOP.
Yes, each and every segment we will cover how to do without CBCT, how to do. Okay. But you are clear in this interforamina, right? Then 4 implants are over. Okay. 1, 2, 1, 2. See, for beginning stage, mandible is very easy to begin with compared to mandible. The patient is having only mandibular teeth problem. Upper teeth is good. Many patients are like that. I don't know why maxillary tooth are still hanging there and mandible teeth they lost. Okay, it's easy to do it. Or even if the both arch are mobile, what you can do is, I'm just telling from your point of view. Upper you can remove and put denture, and lower you can give a implant solution, because lower is very easy to do with decent planning and decent implementation. After 3 or 6 months, either you can do maxilla or you can refer to somebody or you can call somebody and you can do it. When there is a denture in one arch, the opposite arch heals uneven fully, right? Because the denture is there, the lower arch integration will happen very without any problem. Okay, so the lower arch is very easy to start with. Only 2 areas, interforamina and the distal mandible. So coming to the distal mandible.
So mostly I'm asking this generally. What will be the maximum width we place in the lateral incisor?
3.75.
Maximum itself.
Yes, 3.75.
There is minimal width like thin.
You may go for 3.5.
That's all.
That's
Mostly that's all.
More than 4 I have rarely used in the lower anterior because the socket itself is very thin. Even if you do alveolarplasty, the ridge is very thin.
Either it is lateral or 3.5 is the thing we take.
3.5 or 3.75 is. Yesterday we used mostly 3.7.